This
So today,
conference will
first
now be
section.
recorded.
Okay, that's confirmed. We're now being recorded. So our first session today is about a brief introduction to trauma and the brain. So we have about 50 minutes that I'm going to go through the content of the slideshow and have a bit of a chat to you. Whilst we're going through, there is a chat panel down the bottom. Melissa's already said hi. Hi, Melissa. If you want to put any questions in there, feel free, and I can answer them as we go. I'll try to keep an eye on that. And if not, I'll get to the end and answer questions at the end that are sitting in that panel there. I'm also just collecting names of everybody signing in so we can make sure that at the end of the presentation, Alex is able to send out the certificates of attendance for the webinars and gather that information. So a little brief intro. I'm Danielle Draper and I'm the Director of Continuum Consulting, and we're working with My Forever Family to deliver carer training around the state at the moment. It's been fantastic and we've had some really good reception, and I hope that some of the carers that I've seen in training are with us today, and looking forward to meeting more of you as we keep going. So today's presentation is about trauma and how trauma impacts the brain. I think when we were thinking about topics for discussion in the webinars, we thought this was a really good first starting point. And I guess as we go through the presentation today, I'll give you some ideas about where you could go to get some more information if this is a particular area of interest, and also to consider for the little people that you're caring for. We need to think about the brain and how trauma impacts the brain, because it's the fundamental underpinning of all the children that we're caring for and working with in the out-of-home care sector. And it doesn't matter if children have been removed at birth or if they've come in later in life, every child has been exposed to trauma. And I'm going to talk through what that really means for the children and how it impacts. Okay, now I need to work out how to swap the slide over. Here we go. So firstly, some definitions. Trauma is, in its simplest form, and we do call it simple trauma, is a traumatic event that involves actual or threatened death or injury to oneself or others, around which feeling of fear, helplessness, or horror were present. So essentially, at the point of trauma, the person experiencing the trauma is so overwhelmed, their whole system is totally overwhelmed, that they don't have any opportunity to protect themselves in that moment. When we talk about trauma in that form, we talk about simple trauma being a one-off incident, and by no means is that a simple experience. It's always a horrible experience, but simple trauma would be a one-off incident. Complex trauma is multiple incidences, and it could be multiple of similar incidences. So for example, our soldiers that go to combat, they often have complex trauma because they're repeated exposure to the traumatic scenarios. So we call that complex trauma. And some of the kids that we care for and work with do have complex trauma diagnoses, because it does fit into the diagnostic criteria for trauma, and it can be a diagnosable disorder. However, all of the children essentially that we work with are likely to have developmental trauma, and this one doesn't fit into diagnostic terms at the moment. So it's a term used to describe the impact of early repeated abuse or neglect, separation, and adverse experiences that happen within the child's important relationships. And what's important about developmental trauma is that it's about the relationship, and the trauma is impacted the relationship, which is underpinning a child's early growth and development. So basically, for all of the children that we're working with, there'll be some trauma essentially in that relationship, because there's at least one separation, being the removal from their birth family. Okay. Rightio. So This next slide shows the different types of attachment. And I want to talk to you about attachment today because all of these attachment styles are formed within the brain. The brain being the organ that starts developing first for an infant in utero, and then their first relationship is their primary attachment. Attachment is it's a two-way relationship, but what's important is that the child is the one forming the attachment, and we often say that the adult is the one forming the bond. So we essentially want the adult to love and care for the child because the child's looking towards the adult for that opportunity to feel loved and cared for. So whilst we have the child developing the attachment, the parent is not developing an attachment to the child, the parent developed their own attachment to their own parent. The parent needs to be fully available and in relationship with the child. So the preferred attachment style would be the secure attachment. And this is where we have what we'd hope to be the average arrangement where the baby's born and mum is receptive and baby cries or is hungry. Mum or dad or primary caregiver work out what's wrong, change nappies, feed, comfort, wrap up in lovely little bundles and give them nice little cuddles, and is relatively consistent. So baby cries, is hungry, baby gets fed. And generally when babies are born, we have them on the 3-hour rotation of feeding and changing and develop routine at that point in time because that's what develops that consistency for children. So a secure attachment is when the baby believes and trusts that their needs will be met by that parent or caregiver. The child grows up feeling secure and they tend to be explorative and happy, and they return to their secure base when they want their needs met. So if we considered attachment to be on a bit of a seesaw, with one end of the seesaw being spending time with mum and the opposite end of the seesaw being the exploring out into the community or the universe, we would like a nice even flow on the seesaw so they could move between being with caregiver and moving out to explore and coming back again. The next attachment style is the ambivalent attachment. And so this is where the primary caregiver is inconsistent. So sometimes they're sensitive and they meet the child's needs, and then sometimes they're neglectful and insensitive. So things that could underpin this kind of attachment style are the parents that have a mental health condition, or when there's drug or alcohol abuse. So they're present for a lot of the time and then also not available and not emotionally able to attune to the baby in the other parts of the time. So seeing another few people have started to arrive, welcome. We're just starting off and talking about attachment styles. So when the responder is inconsistent, the child cannot fully rely on that parent or caregiver to be consistent and meet their needs. So the child then presents with some anxious, some insecure, and some angry behaviours. And these behaviours, while they develop early in building that relationship, they're the behaviours that are actually sustained and the ones that you might see being caregivers. The next attachment style down the bottom right-hand corner here is the avoidant attachment. Now, this is where the mother or the caregiver is distant or disengaged. So this could be more complex mental health, so significant depression, postnatal depression can be impacted. The caregiver is distant, disengaged, and not actually paying any attention to the child. So what we notice at that point in time is that the child subconsciously believes that their needs won't be met. So sometimes they consider not even bother asking anymore, and they don't show signs. So some of you that may have some children that have entered your care a little later, or babies that have come that are in their later months, they're not responsive. They're not making much noise, not crying, and they're quite emotionally distant, which means, I guess, in presentation, they may not make any eye contact and not be looking around for getting their needs met. So these children are actually not very explorative and they're emotionally distant. So when we think about that seesaw again, if the secure child has got a nice gentle flow between staying next to mum and exploring the universe, the ambivalent attachment, they get stuck in exploring. So their seesaw doesn't move anymore. They're just stuck exploring. And then the avoidant one, they're stuck not doing anything, and quite the opposite. So that leads us to the disorganized attachment. And this is when the caregiver is extreme, so goes to extreme ends. So if you think about some volatile behaviours, they might be frightening, they may be incredibly passive, and the child ends up being really confused. They're unsure about whether they will get their needs met or whether they won't get their needs met. So they can be depressed, they can be passive, they can be angry, or they can be non-responsive. But what's happening for their seesaw is their seesaw is going really fast. It's going between exploring and wanting to go back, and it's really confusing and difficult for them in that space. Okay, so this list is some common causes for developmental trauma. So obviously child abuse, any physical, sexual, emotional or medical abuse, neglect, not having their needs met. This one's about being witness or victim of violence. So thinking about witnessing domestic violence, if the child's witnessing their primary caregiver be abused, that's going to be a traumatic experience for them. Exposure to substance abuse in utero, so the use of drugs and alcohol while mum's pregnant. Bullying in the school environment, this can be traumatic. Grief or loss, so we also need to consider the impact of simply removal of children. So just the child being removed from their primary caregiver can be grief or loss. For kids being moved and leaving behind their pets, or being moved between placements, creates grief and loss. Cutting off from other external family members, such as, you know, grandma having a role in their lives, working or being in a school environment that they need to move schools. Those things can also be traumatic. And the final one is war or terrorism. So across my time working in child protection, I've come across a few refugee children that have got significant developmental trauma, and that's a result of their experience in war or terrorism, and then their experience in refugee camps, leading to significant developmental trauma. Okay, so thinking about trauma, and I guess now we know we have the important relationship that we're trying to build within children, and we have the causes of developmental trauma. I'm going to go through the brain and how the brain develops first, and talk through what happens at different points in time as the brain is developing. So the first part to develop is the brain stem, and that's the bit right down the bottom, just under the arrow for the reptilian brain. So the brain stem, it's fully developed by the time a baby's born. It's responsible for heart rate, breathing, sleeping, letting you know whether you're hungry or not. And it's really the foundation for the brain. So if we think about children that have experienced drug use in utero, and also there's current research about children who experience domestic violence in utero, if we think about that baby being inside the uterus, mum is in a situation where A, she might be using substances, or B, she's victim of domestic violence, her fear is increasing significantly. And as her fear increases, her cortisol is rushing through her body because she's in fight flight, and this is impacting baby in utero. So if mum is always in fight flight and her cortisol is running through her brain, running through her body, baby is essentially swimming in that level of stress, and it's interrupting as early as the brainstem. So if you think about the stem of a plant and how the plant can only grow as well as the stem of a plant is, then the stem of the brain is similar to that plant stem. So if there's already stress on that growing brain stem, then we're already in for some significant differences in that developing brain. So after the brain stem, we've got the cerebellum. And the cerebellum's the bit, they call it, looks like a cauliflower, and it's just where the blue arrow is pointing to in the reptilian brain. This particular part of the brain is about where our body is in space. So we know when we sit down, our bum is going to land on the chair, and we know that because our cerebellum tells us where our body is in space, and we can predict that when we bend our knees, our backside is going to hit the chair. It's also responsible for our posture and for our balance, equilibrium and muscle tone, and all of our physical movement. So if you can imagine, we've already got a compromised stem, and then we're building off this important trunk from our stem with really solid branch here. And this is impacted in utero by that cortisol, by that stress, or by that drug use, or both at the same time. We're going to have kids that have poor muscle tone, poor balance, and have trouble finding themselves in space. So we notice that they're more clumsy than the average child. And this is probably ringing true for you as carers when you're thinking about how often the child in your care falls over or bumps themselves or knocks things over and things like that because of what they've been exposed to in utero. So this particular part of the brain develops up until 24 months, but we need to know that it's being built on that brain stem that's been built in utero and is fully grown by the time the baby's born. So in between, and this arrow, orange arrow for the limbic system fits in the middle, and I'm going to come back to that bit. But I'm going to talk about the bit that goes over the top. So this is what we sometimes call the upstairs brain. This is our major processing center, and it develops between the ages of about 2 and 6. So we're obviously looking at the side view of the brain here. If we were looking at the front view, we'd have a split down the middle. And as this bit's growing, we're looking for the brain stem, the limbic system to vertically grow upwards, but we also want it to fuse together horizontally. So both halves of the brain are fusing together horizontally by neural pathways being built in between. We call that horizontal integration, and that helps bring the brain together and function between both sides of that cortex. This is kind of, like I said, the central processing center, or the main supercomputer, and this is where everything is stored. So complex thinking, memory, our attention, perception, awareness, all of our language development sits in here. And if you imagined the brain was like an orchestra, this cortex would be the conductor. So it's the part that's running this ship, or spaceship as we call it in therapy. The cortex is the director of all traffic. So I'm going to move back now to the bit that's in the middle, the limbic system. Oh. No, I've disordered myself. I'll go back to that one. So we've got this middle kind of slice of the brain that's in the limbic system. And in here, we've got the amygdala, which is the green bit, and we've got the hippocampus that sits around the back of that. And basically, all of our survival responses come from the amygdala. It's going to process our emotions, and particularly anger and fear. They're the first ones to develop. And sometimes it's called the smoke detector of the brain. So when the amygdala senses any kind of threat or danger, then that's the one that kind of goes off like a little alarm state. And what it does when it goes off, it disconnects the top part of the brain with the bottom part of the brain. And when we do that, it means that we can't access any kind of rational thinking. So if you think about our children that we live with, care for, work with, there's often times when they're in a state and there's no ability to rationalize with them. And that's because we've lost the connection between the upstairs brain and the downstairs brain. And some of you might have already seen this one before, but Dan Siegel calls it flipping the lid. And we can use this to help kids that we're working with or living with understand how our brain works. So it starts with having the fist. And if we think about the spinal cord running down this side of the brain, and we have the bottom part here, this nice solid bit, as being our brain stem. And then we have this part over here that's our limbic system. It sits over our brain stem. And then inside here is our amygdala. So we fold our limbic system over the top, all of our emotions, thoughts, and feelings. And then over the top of that, we pull down our cortex, our thinking part. So perceived danger, and I'm going to say perceived because the danger might not actually be present, but the child may just think that there's danger present. The amygdala goes off. And once the amygdala goes off, then the lid flips up. So we have no connection between the cortex and the brainstem. So our downstairs brain and our thinking part of our brain can't connect to each other. So therefore, there's no impulse control. This thinking part of the brain is the part that's saying, hey there, just hold up a bit. Let's think this through. Well, that's gone. That's out the window. We're relying on our brainstem. We're relying on all of those, all of the enzymes, emotions, all to go into our brain stem and to help us run or fight or flight or potentially freeze in those circumstances. So that's how our brain works. How are we all going? Are we hanging in there? So trauma not only impacts the way that that whole brain stacks up on top of each other, it impacts how the brainstem is built, how the, go back to this one, how the brainstem's built. It impacts the amygdala because it's oversensitive with fight or flight. It impacts the cerebellum, and then essentially it then impacts the cortex, because if you've got a rocky bottom, you're not going to have a fantastic rooftop. If you've got shaky foundations, then the rest of the brain is going to be impacted by that. So whilst the amygdala is the smoke detector of the brain, the hippocampus is what we call the memory puzzle sorting center. So the hippocampus takes all of what happens to us day in, day out, and it keeps it in there and it sorts it out. And it sorts out, what do we need to remember for tomorrow? What do we need to remember for next week? What do we need to know how to do? And Those kinds of things all go and sit in the cortex. So when that hippocampus is overwhelmed, so for example, in a traumatic event, something happens, the hippocampus says, oh, actually, I'm not sure what to do with that. And at that point, the hippocampus doesn't process that. So that can actually stay, the images or the feelings in the body can stay and come back to us in flashbacks or nightmares or things like that. So talking with some carers this week, they talked about one little girl who was screaming every night and having nightmares in her sleep every night. And that's her brain actually kind of in a bit of a loop. It's not processing the trauma that's happened, and it keeps coming back in nightmares and flashbacks because the hippocampus isn't able to process that. It's too much. It's overwhelmed the hippocampus. So the amygdala matures at birth, so it can actually register fear in those final months before the child's born. So whilst the amygdala is actually working, the hippocampus is not yet. It's and the cortex is not working yet. So we can't actually keep a memory of why we're scared. So if you think about the trauma happens, the amygdala is working and saying, oh, fear, oh no, smoke detector's going off, but the cortex isn't developed yet. So there's no place to put context for that. So there's no language, there's nothing around that. And that means that the child's holding on to a memory of fear, but the memory is held in the body rather than having some kind of language around what does that actually mean. So these children are born, they're born more fidgety, and they're born with a higher fear response because they've developed that already. Okay. Just going to pause here for a minute and find out if we have any questions yet. Don't have any in the chat that I can see, but if anybody wants to ask anything. No questions yet. Okay. So I'm going to move on to memory. Now, this is a fantastic infographic. It's from Nick Abham. I've got the website at the end of the slideshow. They have fantastic resources. This is one in particular that we have laminated on A3 size in our office and use it to talk to kids and also talk to adults that we treat for experiences of trauma. And it just talks through the different types of memory and how trauma impacts memory. So it does certainly apply to the children that we work with, but you might also notice some of these things within yourself or within others around you that have also experienced trauma. So we have two different types of memory. We've got the explicit memory and then we've got the implicit memory. So the explicit memory is the bit that we recall and event-based, but the implicit memory is more the memory that we feel. So in semantic memory, this is our general knowledge, and we store that all over our cortex. So it shows down the bottom, it's stored in temporal lobes and in the cortex. So it's stored in our rational thinking part of the brain. So trauma can affect this part of memory by information like words, images, sounds, and different parts of the brain from combining to make semantic memory. So when we think about our brain and how it holds together and thinking about the two sides of the cortex and the horizontal integration, semantic memory can be impacted by the ability for that part of the brain to be formed. So I just have a question here from Irina. So I'm going to pop in Irina and can you unmute your microphone?
Yeah, sorry, I'm trying to move the thing upwards. I was actually just going to tell you that I really appreciate what you're doing here. I was just going to have a little message on the side. I don't have a question per se, but I must say
Oh,
I
no
can't
worries.
read I was trying to enlarge the email address at the bottom of the thing. I can just see that it's
Aha. So
NICAM, so I would
it's
Google that,
just,
but I can't see the bottom bit. It's just too small. Can't
oh,
enlarge it any
okay.
further here.
So
But
at the very end, I've got the website for you, but it's
yeah,
www.nicabm.com.
great. All right, thank you. Oh, sorry, I didn't
And
mean to
no,
interrupt.
that's totally fine. It's all good. It's great to be interactive. Otherwise, I feel like I'm sitting in my little box by myself, talking to myself. Um, the good thing about Nicabum is if you're on Facebook, look them up on Facebook, follow them. If you're coming from a professional base practitioner, they have fantastic courses, lots of different things, lots of infographics, and we access them a lot because they're great.
Great. No,
So
I like it. Well done. Thank you.
I'll let you off, Irina. Thanks. Okay, move back over to now looking at episodic memory. So this is our process of what happens and our autobiographical memory. So who was there, what happened, where we were, and you know, for example, in a particular trauma, we tend to remember it like a video. It's like we have a video recall because our brain hasn't been able to unpack it. It's overwhelmed our brain. So we have this fairly clear episodic memory. However, when we have multiple traumas, and for children, first of all, when their brain's not developed fantastically from a spectacular brain stem, their episodic memory is impacted because there's so many traumas that have gone over the top of each other, and it's difficult to remember from start to finish what's happened. And so you can see where that is in the hippocampus, and it's this is the part that's responsible for recalling episodic memory. But when we have a trauma, that overwhelms that episodic memory and we're not actually able to access that. Okay, so the next one is emotional memory, and this is how we felt when something was happening. So, what happens for children when they feel under pressure at different times, or if they feel like they're headed back to a situation where they're in their trauma space, they're having that wave of feeling and emotion that they felt at the time. And often we see this as shame. So, shame or anxiety is really significant for them. And if they think that they're going to be in a situation where a trauma could happen again, then the shame and the anxiety can be overwhelming. And we see a lot of the kids that we work with and that we talk to that we see a lot of them experience an enormous sense of shame, but they also don't want to try anything new because the thought of doing that is very stressful, and it's the shame. And so that stays down in here, and it's the amygdala that's sending off that emotional memory. That's the smoke detector saying, oh, you could be in this experience again, and we may feel that shame. And then finally, we've got procedural memory. So this is how we perform something without having an active thought process. So we often refer to it's like riding a bike, but trauma changes that that procedural memory for us, and often we don't remember how to do those things. And so for people that come back from combat, that's something that we notice is impacted because of the impact on their brain from that trauma. Okay. So now I guess is the important parts. What can you do? What can you do to help the kids that you're caring for with their experience of trauma and the impact on their growing brains? First of all, is about stability. Stability and consistency. And we talk about routines, and everybody says how children love routines. They really, really, really do love routines, even when we tell them they don't love routines. So being stable, being consistent, trying to have as little change as possible in your day-to-day life and having really clear household rules that stay the same. I guess when I think about my house and I think about Saturday nights, it's like free for all. It's like whatever we can find for dinner, we'll throw in, we'll have it at whatever time we want, we'll watch whatever, we'll do whatever, something will kind of happen. Kids with trauma histories, they don't cope with the unpredictable. It needs to be predictable and it needs to be stable. Any kind of change or shift in circumstances can create that anxiety, and that amygdala can go off. We need to accept their emotional outbursts as a form of communication. So instead of, why are you doing this? It's, what are you telling me when you're in this space? What are you telling me is happening for you right now? Behaviours are not intentional to harm. They're not a deliberate attempt to make things difficult for you. It's communicating, and it's the body communicating. And at the time that the child is doing that, their rational brain is offline. It can help make kids feel safe. And it probably sounds kind of cliche, but the calmer the environment, the softer the voices, no arguing, all of those things that we aspire to have in utopia will help a child feel safe. But also having a safe place for them, somewhere that they can go or be that feels safe and that they know that you're close by. So it's not about sending to a room or giving time out or putting them separate from you, but being in a spot where they feel safe. Some really good ideas for safety are things like a hammock. And recently we shared on our Facebook page, it's like a net that hangs from a central point in a ceiling, and it's like a hammock chair, or kind of like one of those baskety things that you carry groceries in, but human size. For children, that, or a hammock that actually wraps right around and comes up to that central point, is a really good safe space, because it's almost like being back in the womb. It's all encompassing around. It's actually like if you're in water, it's buoyant, it's up in the air. There's nothing else touching except for the firmness of that fabric or net wrapping around them. Really good safe space, and it swings, it rocks, and it spins, and they're fantastic for vestibular systems. So that kind of thing. Another safe space is in water. So using baths, we tend to grow children and get to a point where we think, okay, they're able to hop in the shower themselves now, so let them go and have a shower. Actually letting them sit in the bath is a really nice safety space, because they're buoyant, there's nothing else touching except for the water or the bottom of the bath, and you can create safety for them. We can teach kids about breathing, how we can calm and get some emotional control. We can't teach kids about breathing when they're in the middle of the meltdown. The best time to teach kids about breathing is in all the time outside of the meltdown. And by having ongoing breathing or ongoing healthy breathing exercises when they're calm, actually keeps them in a calm state. And one of the other webinars we've got coming up about emotional regulation, we'll talk about window of tolerance, and we'll talk about staying within that window and how we can do that. But teaching breathing techniques to use when they're actually okay, because that will help them stay okay for longer. Other breathing kinds of strategies you can do is blowing things, blowing bubbles. And often, you know, when we're playing bubbles with children, we do the bubble blowing and they run around and pop them and all of that. But instead of upregulating, getting them to actually blow the bubbles can help them breathe out and retain that calmness and relax. We can try to learn what the triggers are for children. And whilst we say that, it's not always easy. It's really tricky, because the children won't know what their triggers are either. These are all very subconscious things, and they can be related to events that happened prior to the development of language. So we can try and learn, however, it's a tough gig. It's a tough thing to try and learn triggers. It's probably easier to start learning about what the early warning signs are, so we can help them calm earlier before they get into full meltdown. Can help them with simple movements and activities that can help your child regulate, and things like that can be rocking, swinging, soothing, often being wrapped. One of the ones that we like to do is the human burrito. So when we've worked with kids that are a bit older, just wrapping them up in a blanket like the sausage roll, to keep that real firmness around them. Or in a beanbag, things where they can have some firmness around them in that relaxing downtime. Okay. So here is that website for anybody that does want to write that down. So that is the Nick Cabham website for good resources. I'll just leave that up there for a moment. And I'm just going to take a moment to write down the extra people that have come in, so we have everybody on the list. And while I'm doing that, the next slide is going to be asking about any questions that you have. So please do feel free to pop any questions in the question panel, and I can get started on asking those. Okay, no questions so far. Okay. So Alex has just flagged, can we make the slide pack available to send out to you? Absolutely. So we have a PDF document that we can send out post the presentation. So you've got a copy of those, particularly the website, because it will be really good to refer back to. And we will also provide a copy of the recording, and My Forever Family will be able to pop that on their website. Okay, Renee has asked, what does it look like when a child is stuck with exploring? So referring back to that, the seesaw with attachment, you'll notice some children are stuck with their carer, they don't leave. So there can be separation anxiety. When they're stuck in exploring, they actually have no desire to go back to the carer, because they don't actually get anything from that caregiver. So they tend to be the children when you go and see them, or they come rushing up to you and giving you a cuddle and they don't know you. That's actually stuck in exploring. So back in my past life as a child protection caseworker, knocking on the door of a home to go in and do an assessment, and children have never laid eyes on you before, but you've opened, the front door's opened and they're already all over you and climbing all over you. That is actually stuck in exploring. So they have an avoidant attachment with their primary caregiver. Now, some of the other ways you may see that, and in my current role, I also do work for the Children's Court Clinic, and a way that I see that in working with children, and particularly with babies, watching a parent pick the baby up and they're turning their head and they're arching backwards and they're actually trying to avoid that eye contact with the carer, because they're not getting what they need from there. So we call that stuck in exploring. Okay, Alex, I think I already covered that. We'll have the website on we'll have the recording on the website that you can look up, and Alex can probably provide directions as to where to find that. Okay, Michelle, so some early warning signs a child's been triggered. It can be different for every child. Some of them retreat and go within. Some of them might stare off into space, and that's the point where they're outside of their window of tolerance, and it's like they're moving into a dissociative state. So they can be staring off into space and disengaged and not able to be contacted in the present. For some children, they'll start getting irritable, so their arousal symptoms are going up. So when we think about meltdowns and we think about what does a 2-year-old look like when they're having a meltdown, what do we see just before they start doing that? They start getting irritable, they start getting fidgety. And that's when, if we're attuning sometimes to those children, we might go, okay, so we're actually in a situation that's outside of your capability to be engaged here. They may start getting more emotional. So some of the things that are happening just before we go up into full-blown meltdown. In talking to some carers the other day when I was doing a behaviour support plan, she spoke about one child just went from 0 to 100 very quickly, and she couldn't actually see any early warning signs, and that can be the case. When we talk about emotional regulation in one of the upcoming webinars, we'll be looking at a bit of a process to show how we move up and back down inside and outside of our window of tolerance, and that will be something that we can look more at then. Okay. I'm going to move on to, oops, we had the question page up. And I thank you, everybody. There's no further questions. Just doing a little scroll through. Aha, so Alex just wants to give some messages just before we wrap up. So Alex, if you want to switch on your microphone, and I'll hand it over to you.
Thank you, Danielle. Hi, everybody, and thank you so much for joining in on our very first webinar at My Forever Family. We're very excited to have Danielle doing these webinars for us. We have a lot of them on our website, so please, everybody, go onto the website, myforeverfamily.org.au, and register for the rest. I think we have 11 coming up in the next 7 weeks or so. So thank you, Danielle. We really appreciate your time. It's been wonderful and really great for us to learn a little bit more about what's going on in our little people's heads. Thank you.
Thanks, Alex, and thanks, Michelle. Thanks so much, and look forward to next time. I'll close off the webinar and